Bonjour, my name is Xavier Leleu. I'm professor of hematology, expert in myeloma, and I work in the city of Poitiers in France. So at I-Dara and ASCO, we had another study that we presented, IFM 2018-02, which is about ixazomib-daratumumab without dexamethasone, this time in elderly, frail patients in the relapse setting. It is a phase 2 study, and so again, it is an IFM study. It was conducted by Dr. Margaret Macro, and the sponsor was the hospital of Dr. Margaret Macro, the hospital of Caen. So why have we been looking into this small phase 2 study, sort of proof of concept? First of all, we see in France, but I think it's worldwide, or at least in most of the Western countries, that there are many myeloma patients diagnosed in the elderly. And we have the feeling that we have never seen that many myeloma patients in the very elderly patients, above 80, above 90 years old, and possibly because now this patient lives much longer than they used to be and live in a much better shape globally than they used to. We have heard, we have experienced, and we have published and being part of studies largely demonstrating that for these patients, they likely have 1 or 2 lines. And part of the most important aspect of their treatment is the safety profile, is that efficacy is definitely not sufficient for these patients. If the safety profile is not as amazing as the efficacy, the treatment will not work for these patients. And safety profile is one of the main reasons for this patient to die or stop treatment and then die. While the treatment could be convenient, while the treatment could be a great progress, while the treatment could be active. So we thought, and on our experience, again, there's a lot of studies to report to. One of the most incredible one and most recent is from Alessandra La Rocca, Blood 2021. Dexamethasone is probably today the first drug, the number 1 drug to be considered as most toxic. Initially, it's very active, but slowly over time, probably the benefit drops and the side effect profile increase. So we thought to give an ixazomib-daratumumab combination because the patient received lenalidomide up front and without dexamethasone, because in this frail population, extremely old, we didn't want the patient to suffer from the dexamethasone. So the patient were to be frail and elderly, 1 or 2 prior lines, frailty score greater or equal to IXA and DARA naive, globally in not too bad a shape. Daratumumab ixazomib was given as usual. In that study, daratumumab was IV, ixazomib was 4 milligrams orally. Patients were to receive the treatment until progression, 28 days cycle. Median age in our study was 82 years old, going up to 93 years old. Frailty score was 76% of the patient 2, and 24% of the patient more than 2, 3, or 4. 65% of the patient were in 2nd line and 35% of the patient in 3rd line. High-risk genomic was found in 19% of deletion 17p, 17 to 14, and 60% of the patient had bortezomib, 67 lenalidomide, and 36 were len refractory. Globally, 55 patients treated. The median duration was 13 months. The discontinuation was for 38% progressive disease and only 5.4 adverse events. So definitely, we can say that that treatment was manageable. There was a lot of grade 4/3 treatments linked to ixazomib and daratumumab, but this I'll let you look into the regimens, but the details in the poster and the overall. But interestingly, for all evaluable patients, 76% had a response, partial response and better, 34% greater than VGPR, greater or equal VGPR. But in len refractory, we had, and in high-risk genomic for these patients, ixazomib-daratumumab, no dexamethasone, we had a very similar response rate and greater or equal VGPR rate than in the global population. So this was very reassuring. The median PFS of the studies is 19 months, which for elderly frail, I remind to you, 82 years old median age, going from 70 to 93 years old, having a second line and 19 months, no dexamethasone, a quite, I would say, quite good safety profile was a great plus for the patients. And the estimated overall survival at 1 year is so far, 87%. So we think we demonstrate here that we probably can give to the patients a very similar efficacy to what the regimens are with dexamethasone, but now without dexamethasone. We are convinced we brought to the patient a much better safety profile, and so no loss of activity because we dropped dexamethasone. And therefore, we would like very much that this notion of not giving dexamethasone anymore to patients would be studied in a much larger study. And that has been done in my group. Up front, Lille, Professor Salomon Magnier and Professor Thierry Facon have wrapped up the recruitment of the IFM 2703 that looked at len dexamethasone versus len daratumumab, no dexamethasone, to try to finally confirm in a very large study that in elderly patients, and particularly elderly frail patients, we can and we should get rid finally definitively of dexamethasone, because we have the demonstration, or we will have soon the demonstration, that we have the same efficacy without dexamethasone, but with a seriously improved quality to the patient, quality of life, and diminished safety profile, with all the good, I would say, consequence of this: prolongation of treatment, prolongation of survival, much better quality of life, etc. Thank you very much.